Thank you very much. Thank you very much for coming and, deciding to spend the sunny day in Vienna here inside with us. I think it shows that we care about patient safety and that we all feel that's an area where we can probably do better and where there's area for improvement. So I'm trying to bring all this together and see if there's anything what we can do. Just for disclosures, I'm currently employed at the University of Göttingen. My department receives research funds from various companies, and I have received money and support from Medtronic, 37 company, and Merck Pharmaceuticals. So keep this in mind as we go through the slides. When I started my first day in medical school, one recurring thing that was told to us was, first, do no harm. Don't make it worse. Don't add any additional problems to what you do. And, that was a recurring theme over all those years. And Florence Nightingale, you might recognize, said it also in her notes that the first requirement in a hospital is that it should do the sick no harm. And I assume that most of us are anesthesiologists. I think we can lean back and be happy. We can feel good about this. In 2000, the report To Err is Human came out, and it was a wake-up call on patient safety. But when they talked about anesthesiologists, they said, we're actually doing pretty good. We reduced anesthesia-related mortality significantly. We look good in this. But there's more to it, of course, right? If you just focus on anesthesia-related mortality, we made great advancements and have done good for our patients. But if you broaden your view a little bit and look at the perioperative period of the patient's stay in the hospital, you can plot a slightly different graph. And this graph shows you, let me see if I can hear, total lives lost per year and number of encounters for each fatality. And you see that healthcare is right up here, somewhere in the risk between mountain climbing and chemical manufacturing, only that a lot of more people die here. So we're somewhere between hazardous and regulated. So obviously there's more happening outside the anesthesia-related mortality in the hospital that we have to address to make it safer for our patients. If 30-day mortality were a distinct disease, it would be the third leading cause of death, right after heart disease and cancer. That's how common the problem is, and that's the problem we deal with. 30-day postoperative mortality is about 1% in the United States. It's about 2% for inpatients if they're older than 45 years, and 80% of this happens during the initial hospitalization. That's the problem we're facing, and it's a respiratory problem. About 50% of the cardiac arrests on regular nursing floors have a respiratory cause. Respiratory failure was named by the AHRQ, the Agency for Healthcare Research and Quality, as the fourth most common patient safety event. And cardiorespiratory complications have been identified as the leading cause of 30-day postoperative mortality. Those are sobering numbers, but they also show you that probably it should be anesthesiologists involved in solving this problem. If it's a respiratory problem, that's our domain. Managing airways, managing respiratory problems, managing hemodynamics, that's part of our core business. So probably this also shows that we might have some expertise in helping with this. This is another example just to give you an idea of the scope that patient safety indicators that were named by the AHRQ in 2015. If you just look at the number, let's go back one here. Sorry, right? If you just look at the scope of the problem, there are about 10 observed events per 1,000 for postoperative respiratory failure. That's in the same league as postoperative sepsis, right? This is not a rare occurrence, and it certainly is a harmful one to the patients. And we do have a rough idea of which patients are at risk. There are patient factors involved in this, treatment factors, and care factors. We know that obese patients, patients with severe comorbidities, advanced age, sleep disorders are at higher risk. The surgery type and duration, the anesthesia type and duration, and residual narcotics influence this. Same as staffing ratios, monitoring equipment, and the level of care patients receive after their surgery. All this, and you see if you put it together, and there are factors from each one of those three areas, you can create the perfect storm, and patients end up with adverse events. but they tell us that they're not doing well. In this study, they investigated with monitoring patients before an event occurred. And they could see vital sign abnormalities up to 8 hours, and half of the patients, 50% of the patients, had abnormal vital signs before the critical event actually occurred. And when you look even further, in a time period of 8 to 48 hours before the critical event, still 48%, half of the patients, demonstrated abnormalities. So you can detect abnormalities, and you can detect that there's about something bad to happen. And you can do something about it. This is data from our rapid response team at the Cleveland Clinic. And as you see over the years, as caregivers got more and more comfortable with the idea of activating a rapid response team, and the number of activations went up, early intervention, early assessment of the patient led to a significant reduction in the number of code situations over the same period of time. So patients, we have a rough idea who might be at risk. They tell us with vital sign abnormalities ahead of time, I'm not doing well, and apparently if you intervene, there might be an opportunity to prevent bad things from happening. In this, Tensa did an interesting study where they compared manual recordings and at the same time performed automated recordings. And if you think about your floor, if it's like my floor, nurses run around and document vital signs by hand and write it in the chart. I think that's still the standard. What they found is that the manual recorded values on average were 6% higher than those that were recorded by the automated system. So if you base your early warning scores and your risk assessment on what's written down in the chart, that's 6.5% higher than what an automated reading would be recording. So manual recordings are not very reliable to do risk prediction and automated alerts. In this meta-analysis, LAM, they included 4 studies that use continuous pulse oximeter and 5 studies that use continuous capnoGraphY. And what they concluded is that continuous pulse oximeter monitoring significantly improves oxygen desaturation detection on a regular nursing floor. That's easy to imagine. If you continuously monitor, it's easier to early on detect desaturations. There was a trend towards less ICU admission. It was inconclusive on rapid response activation and mortality. But what they also concluded is that capnoGraphY provides an early warning of postoperative respiratory depression before oxygen desaturation, especially when supplemental oxygen is administered. And what is the first thing that you do on a regular nursing floor if you feel the patient is doing that well? You put on a little bit, 2 liters, 4 liters of oxygen. So in 2010 already, they had a consensus conference talking about how do you identify, what are we going to do about those patients? And the conclusions they came up with, they said, vital sign aberrations predict risk. Monitoring patients more efficiently may improve the outcome, although some risk, some events are just random and catastrophic out of nowhere. If practical and affordable, all patients should be monitored continuously. That's what they said in 2010. And how could that look like? Because if we start monitoring all patients continuously, my hospital has about 1,000 beds, right? If we all of a sudden have continuous data on vital signs of 1,000, that's a lot. Either you can find a lot of people to look at, monitors, or you come up with an electronic solution to monitor those patients. So this could look like something where you monitor a patient continuously and then transfer all this data to a server. And you can have at the nursing station or a physician station a central monitoring system, or you have a vigilance system that in the background with artificial intelligence analyzes the data, identifies patterns, and an alert engine then, based on prediction models and thresholds, can send target alerts either to the floor nurse to check on, depending on the level of alert and the kind of alert, go to the primary service and have the physician check up on the patient, or if it's a bad combination of things, directly alert the rapid response who goes out and assesses the patient. Something like that, I think, we can imagine. And the technology is already out there. This is not rocket science that needs to be invented. The technology is already out there to do those kind of things. And I think soon we all hopefully run around with a tablet where you can assess your patients, you get a live stream of vital signs, you can activate the code team out of the tablet, it shows you the layout of where the patients are. And again, all this is probably a little bit more of programming, but the technology underlying all this exists already. I'm not the only one saying that calling for monitoring is a good thing. This has been around for many, many years. In 2006, the Anesthesia Patient Safety Foundation recommended continuous monitoring of all patients. And there's a Hospital Quality Institute, there is the Patient Safety Movement Foundation, Institute for Safe Medication Practices recommends monitoring in high risk. You see a long list of institutions and associations that recommend monitoring of all these patients. In summary, the evidence shows that cardiorespiratory compromise is common and it goes undetected. Continuous monitoring of capnoGraphY and oximetry can provide early identification of respiratory compromise, allowing for early intervention. The APSF recommends continuous monitoring for all patients receiving opioid therapy in the postoperative period, especially when they get supplemental oxygen. And continuous monitoring of all patients appears to be the answer to detecting cardiorespiratory compromise early on. About 15 years ago, the daughter of Lenore Alexander underwent surgery for chest deformity in California, and she received a significant dose of opioids postoperatively for her pain. And the following morning, the family found her dead in her bed. 10 years later, the mother recognized that there was no lesson learned. There was no change in practice. And she started speaking up and making a case for more monitoring. This has been going on now for 5 years, and we're still talking about implementing monitoring. I think it's time that we stop talking and that we start doing. Thank you very much.